Good morning. Welcome to Grand Rounds today. I will kick us off. Really glad to see many of you here in person, and welcome to those of you who are online. Today our presenter is Christina Vaughan. She's presenting on palliative care in movement disorders. I'll share her bio after a few brief announcements. Our next journal club is next Thursday. It'll be by Zoom, and if you need the link, contact Jacob Walker. The articles will be embedded into the calendar invite. The next Grand Rounds is October 5th. Dr. Mark Ernest will be presenting on narrative medicine, and it's actually going to be quite interactive, so we encourage you to come for breakfast and come for the interactions together. October 12th. Thank you so much. Yep, we are going to meet in September, and we will meet in October. So thanks for that. We will send you an email with a link to the evaluation for this Grand Rounds. We appreciate your feedback on that. And please do feel free to submit chat or questions into the Q&A. We are monitoring. So just wanted to introduce Christina. She is an associate professor of neurology and medicine here at the University of Colorado. She's also chief of the section of neuropalliative care and physician lead of the Anschutz Palliative Care Clinic. She completed fellowships in movement disorders at Rush University and palliative medicine at UCSD, Scripps. She has 6 weekly neuropalliative clinics here at University of Colorado and one at the Rocky Mountain VA, where she sees patients with several different chronic neurologic conditions. She also attends inpatient palliative care at UC Health Hospital. In her role as a clinician educator, she is heavily involved in teaching at all levels of medical training and is also participating in several clinical research studies with Benzie Kluger, Carrie Levy, and others. One of them is as a palliative care coach for the Parkinson's Foundation, where this is a national project to implement primary palliative care for people living with Parkinson's disease in community-based neurology practices. So it's really great that Christina, Dr. Vaughan, is here with us to present on palliative care and movement disorders.
Thanks so much, Hillary, and thanks everyone for this, for being here in person and virtually, and for the opportunity to speak with you. I think a lot of friends in the room and virtually, I'm sure. So what I'm going to set out to do today, it's kind of a broad topic, and I tried to narrow it down as best I could. What I'll attempt to do is to highlight 2 specific movement disorders and just a brief overview of what movement disorders entails as a specialty. And then we'll get more specific, highlighting 5 unique palliative care features of neurologic conditions, specifically movement disorders, the 2 that I'm focusing on. And then I'll end with 2 cases in an effort to kind of make this more like an old school Grand Rounds where we interview some patients. They'll both have Parkinson's disease, but that's the most common of the movement disorders. So I think that, and I'm sure you all see this on a regular basis. So very briefly, movement disorders, as you may know, is a subspecialty of neurology. It requires a fellowship after neurology residency. It's usually 2 years. It focuses on movement affecting complications that don't fall really under any other established categories of disease, making this group kind of difficult to understand. And we claim specific diagnoses that really surround either moving too much or moving too little. Examples of moving too little would be Parkinson's disease. Even though there's a tremor and ultimately dyskinesia, at the essence of it, it's moving slowly and there's a paucity of movement. Stiff person syndrome also falls under the category of moving too little. Most of these other diagnoses, chorea, et cetera, are about moving too much. And this picture here is a little shout out to Dr. Vaughan. He's doing that test of retropulsion that we also often do for balance testing in Parkinson's. He's one of the grandfathers of the field. He started the first movement disorders program at Columbia a long time ago. He's well into his 80s now. So when I did a PubMed search, just with the search terms neurology and palliative, nice uptick in recent years to show that this is becoming a much more common marriage between palliative care and neurology. I didn't bother to do specifically movement disorders because I would have had to break it down, but really nice to see the trend here. Coming up in neurology journals more and more frequently are indeed studies or surveys of the the importance of palliative care in specific movement disorders, Huntington's disease, and Parkinson's disease. As Hillary mentioned, this initiative came out of the Parkinson's Foundation, the largest foundation for Parkinson's disease. They rolled this out, 3 years ago about, and Hillary and I have both been working on this project. It involves coaching centers of excellence designated by the PF. There are about 33 of them across North America, trying to roll out or implement primary palliative care, focusing on 5 pillars: non-motor symptoms assessments, caregiver assessments looking for evidence of burden, spiritual and emotional support, advanced directives, and specialty referrals to hospice and palliative care. And Carrie's going to be involved in a very similar study across VA centers throughout the country soon. So what are some of the unique unmet needs of these neurologic conditions, particularly movement disorders? Studies have shown that there's really poor communication and inadequate support when it comes to giving the information about the diagnosis and providing psychosocial support at that time and then throughout. It's been interesting to do some qualitative studies, hearing about people's experience when they've received the diagnosis of Parkinson's and the struggles that they have trying to make sense of that, process it, and get the support they need at that time. There's also a relatively lack of standardization when it comes to goals of care discussions when people are living with these conditions. There's definitely an under-recognition and under-treatment of symptoms. So remember, I'm talking about movement disorders, and when you think of movement, you think of what you can see. And there are a whole host of invisible symptoms when it comes to Parkinson's and Huntington's. Even though you might be really focused on the tremor or the dyskinesia, the chorea, there are just a variety of invisible symptoms, from fatigue to mood disorders, et cetera. And these are often under-recognized and under-reported, and certainly big sources of suffering. There's also a lack of systematic approaches historically to care partner support and spiritual well-being, hence this initiative by the PF to try and focus on these aspects. And then lastly, low rates of advanced care planning historically and discussions around this. And it's been really eye-opening when I do these coaching sessions with different centers around the country, talking to some of my senior colleagues in the field of movement disorders, hearing about their discomfort. They're like, well, I don't talk about that. You know, that's a downer. Why would I talk about that? We're focused on tremor and movements and things like this. And so it's been really eye-opening to recognize the reluctance to have these kinds of discussions, especially in a timely way earlier in the disease course. And then hospice referrals have been low, and that's another point in the pillars of the project that I mentioned, trying to move the referrals a bit sooner. It's hard, certainly, to prognosticate in Parkinson's and other movement disorders, but at least having an awareness on the part of the providers to think about it earlier so that we're not referring patients to hospice necessarily during a crisis when they might just have days to short weeks and miss out on the potential for 6 months potentially of extra support. So these are some themes that I think really drove the initiative, that Parkinson's Foundation project. So I'm going to focus on Huntington's and Parkinson's disease. Parkinson's because it's so prevalent, and I'm sure you see it often. Huntington's because although you may not see it quite as often, and oftentimes people aren't living into geriatric stages of life, there are a lot of opportunities for palliative care support. And there are some key features that people aren't necessarily familiar about HD that I'd like to highlight. So does anyone recognize that gentleman? It's a small picture in the corner. What's that? Yes, thank you. That's Woody Guthrie. So he wrote This Land Is Your Land. He was a folk singer. He remains really the most famous person. He's not that famous at this point in time. Most famous person with Huntington's disease, which is quite different than Parkinson's, which we can think of a whole lot of different people, celebrities and so forth, that have a PD. So he's our most famous person with Huntington's. So we don't necessarily have a concept as a population of what HD looks like. But as you probably remember, it's a slowly progressive autosomal dominant neurodegenerative disease. This is the most common genetic form of a neurodegenerative disease that exists. It really is more than a movement disorder, as I mentioned. So certainly the movements look like chorea, involuntary writhing, dance-like movements. They can also have dystonia, sustained muscle pulling, particularly for younger onset patients. And then at the end stages, they often have Parkinsonism. And the treatments for the chorea can cause Parkinsonism because they're dopamine blocking. So those are the motor features often seen in Huntington's disease, but it also includes cognitive impairment and psychiatric symptoms. So it's sort of a trifecta in terms of different types of disability that patients have with HD. Prevalence is at least 12.4 per 100,000 individuals. And when it comes to prognostication, this is the range, 10 to 30 years of living with HD. So that's not super helpful. That's a really broad range, but it depends on a lot of things, right? It depends on time of onset, how young they were when they got it, comorbidities, and so forth. Important points that you may not realize that I'll highlight here include that among the neurodegenerative diseases, the suicide rates in HD are the highest. And completed suicide rates are estimated at 5.7, but nearly 30% of patients with HD have attempted suicide. And in some cases, this is due to depression. In other cases, it's due to rash or impulsive behavior, which can be a big problem in HD, just making a rash or sudden decision to do something radical. And so this is something to really keep in mind when we're seeing patients living with HD. They may not even admit to depression in the visit and then later have an impulsive attempt. Weight loss is also common in Huntington's, important to remember, and this can be despite a normal or even high caloric intake. Sometimes it's due to the significant energy expenditure that they have as a result of the chorea. It takes a lot of energy. There's so much movement. And then, of course, to maintain their balance in the face of chorea also takes a good amount of energy. They develop swallowing disorders over time, oftentimes, so that can certainly impact weight gain or weight loss. The depression can contribute to reduced appetite. And then there is involvement of the enteric nervous system in this condition like there is for Parkinson's disease, and that may be playing a role as well. But when you see people living with Huntington's, particularly in mid and late stages, they're very skinny for the most part. So some of the palliative care needs, important to think about them in the context of the stages of Huntington's. And unfortunately, when it comes to staging, both with Huntington's and Parkinson's disease, we really struggle. Patients, of course, often want to know, what stage am I at? And I now work, our clinic is in the cancer center. And so we're it's easy to juxtapose like cancer care versus our neurologic patients. And cancer care often has better staging, right? They can look at a biopsy under a microscope and make predictions, and it dictates treatment. But with diseases like Huntington's and Parkinson's, our stages are strictly based on function, where they are in the course of their illness and what they can and can't do. And each stage comes with a variable time of years or variable interval. And so stage 1 is, minimal involvement of chorea. Maybe they occasionally need a hand with something like buttoning, for example, and they're still able to work. Stage 2, somewhere between 3 and 13 years into the disease, usually unable to work at that point and needing a more consistent level of assistance. By stage 3, they're requiring major assistance, and this is somewhere between 5 and 16 years into the course of their HD. And then by stage 4, maybe they can perform some of their activities of daily living, and they're either living at home with home care coming in or at a facility. And by stage 5, definitely in a facility, usually bedbound, very skinny, and full-time nursing is necessary, usually at that point. So that's, in general, the staging of Huntington's disease, which you can imagine offers a lot of opportunities for palliative care involvement. Some of the milestones along the lifespan of living with HD that are unique are, because it's autosomal dominant, you can imagine that oftentimes the patient is aware of a parent. There are still cases where it seems like it's out of the blue. Somebody has HD and didn't realize that it was in the family because either that family member died or is estranged, or this is a new onset. It's an older person developing HD, and it's the first affected patient in the family. But usually there's a family member, and therefore they're aware of it and have to make the decision, do I want to have predictive testing or not? So this becomes a point of genetic counseling involvement, oftentimes ethical discussions, family planning, and so on. Then moving forward, symptoms become apparent in general in the 30s, maybe 40s, unless this is a Westphal variant, which means young onset in the 20s or even younger, which is rare. So in the 30s, they're becoming aware of maybe being clumsy. And then moving forward, perhaps their affected parent dies. And that is a huge stressor to witness, of course, the end of their life with HD and then their ultimate death, probably earlier than it would have been otherwise. And then at some point along the way, they're stopping working, stopping driving, and just progressive losses. And then at the end, considering a nursing facility. So these are at least potential time points along the trajectory that we can anticipate in some cases and consider wraparound support, or at least interdisciplinary support, collaboration with the neurologist, and trying to provide emotional support in advance of these milestones and after the fact as well. So I think it's a useful trajectory to think about in terms of what we can predict and how we can provide support. Another way to look at it as opportunities for palliative care or team-based support would be at the time of diagnosis. And I think this applies to most conditions, honestly, in neurology. At the time of diagnosis would be a great time to introduce palliative care, to discuss goals of care, to at least have documented medical power of attorney. And then not long after that, another visit to meet the team, the interdisciplinary team, to include the chaplain and potentially a social worker to provide or at least introduce what spiritual care support could look like. And then starting to recognize some of the more complex symptoms that might be occurring, trying to address those. And then trying to really make sure that the patient feels like they have a team and that we're part of the team in palliative care. Moving forward some more in the timeline, considering more discussions around prognostication. As I said, of course, it's really hard to prognosticate in these neurologic diseases, but once we've had several time points and have a sense of trajectory and slope of change, we have at least a bit more data to go off of when discussing prognosis. We might discuss legacy work at that time with our chaplain and so forth, and just be thinking about the what ifs of the future to aid down the road in decision making. Ongoing family meetings along the way. As you can imagine, there's a lot of stress when people are having multiple generations of the same disease, potentially in the family. Introducing hospice, just as, normalizing it and saying at some point, this might be of particular benefit. And then further down the road, ongoing management of symptoms, care transitions into a facility, perhaps helping support the family at that time. And then hospice involvement ultimately, and then the bereavement support that comes after that. So these are all potential opportunities for palliative care involvement in the trajectory of HD, and I would say the same in Parkinson's and a lot of our neurodegenerative diseases. So that's all I'll say about HD as an opportunity for palliative care support, as well as some key features that you may not have been aware of. So naturally, this is my transition slide to Parkinson's disease. As I said before, it was just Woody Guthrie that we have in HD. We have a whole host of people when we think about what Parkinson's looks like. Nonetheless, there's no one way that Parkinson's looks like. You've seen it. It can have tremor. Sometimes it doesn't ever have tremor. Rest tremor is present in about 60% of patients, and then the rest never get tremor. And oftentimes the patients with tremor say, oh, I wish I was one of those folks that never got tremor. But in fact, the course of Parkinson's is a bit worse for the people that don't ever get a tremor. These are the postural instability, gait disturbance, PIGD phenotypes of Parkinson's. Those are the folks that are more likely to have a slightly faster progression and more likely to have more cognitive impairment and psychosis somewhat compared to their tremor predominant counterparts. So just to be aware, not everyone with Parkinson's gets a tremor, and certainly not all tremors are Parkinson's disease. So some highlights here. I'm not going to go through Parkinson's disease because you all know that, but I am actually giving a talk tomorrow to geriatric fellows all about Parkinson's. So feel free and jump onto that at 8, and we'll really get into the details of PD. But I want to remind people that Parkinson's disease contributes to mortality, and there are certain signs and symptoms that predict the terminal phase of PD. I think it's really important to dispel the myth that Parkinson's doesn't kill patients. And I want to say that I was very guilty of this. When I was in training and fellowship, I learned that when we diagnose people with Parkinson's, part of our spiel includes, you have Parkinson's, I'm really sorry, I'd rather you didn't have this, but I want you to know that, it's not going to kill you. You live with it, you die with it, you don't die from it. And that really made us feel better, you know, when we gave that diagnosis. It just sort of softened the blow, and it was coming from a place of good intention. But I think, and lots of the seniors in our field also said that, you know, one senior, the head of the Movement Disorder Society, was known to say, you better find something else to die of because it's not going to be Parkinson's, very kind of cavalierly, but it made patients feel good, I think, for the most part. But it's very misleading. That's not to say that everyone with Parkinson's is going to die from it, but we can't overlook the fact that it's possible. I can't tell you how many people I've seen die from Parkinson's disease, and we just don't want to overlook that fact. It is the 14th leading cause of death in the US per the CDC. It fluctuates between 13 and 14, maybe 15, but nonetheless, it's on the list. And that's an important point. You know, it's going on death certificates as cause of death. 71% of people will die from complications of their neurodegenerative disease. And the chances of dying from a Parkinson's related cause is 78% for those who live long enough, on the order of 12 years with the diagnosis, and they reach Hoehn-Yahr stage 3. As I mentioned, staging in Parkinson's too is really based on function and the snapshot of what they look like in the clinic on the day you're seeing them. Hoehn-Yahr stage 3 means that the person is still functioning independently, but they're using an assistive device to walk. Their balance is impaired. That retropulsion test that you saw on the other slide, they need to be caught, or at least are struggling with it. It's not normal anymore. So that's what we mean by Hoehn-Yahr stage 3. So again, the point is that the chances of dying from Parkinson's related cause is on the high side if somebody reaches that level of function or dysfunction. So the commonest causes of death when people are living with Parkinson's include sepsis, respiratory failure, wasting syndrome, and choking. Other features that are helpful in predicting that we're in the terminal phase of Parkinson's, meaning the last 6 to 12 months, include a BMI less than 18.5, accelerated weight loss, a significant reduction in dopaminergic meds due to the neuropsychiatric side effects. So as you're probably aware, in the patients that you see, when they've had Parkinson's for a long time, sometimes less is more. I know that's a basic tenet in geriatric medicine too, is trying to think about, you know, overprescribing and deprescribing and so forth. But oftentimes the levodopa, which is our mainstay drug still, causes more problems than benefits in later stages. And so we often have to dial back the medication because it's causing too much psychosis, confusion, episodes of orthostatic hypotension. These are all reasons that we would pull back the levodopa in later stages of PD. So that's one of the other factors that might suggest that we're in the terminal phase, or that the last year of Parkinson's. So what are some unique features of movement disorders to highlight here, both PD and HD, and potentially others? So important to think about illness trajectories comparatively. And so in neurology, we tend to look at these different trajectories. And this is an old article by Dr. Holloway out of Rochester, but it's a nice pictorial image of potential trajectories. And so in the top left, we're seeing a trajectory that you might find in ALS, sort of like a diagnosis, a slight decrease, and then a drop off. In top right, that might be in line with multiple sclerosis, refractory epilepsy, organ dysfunction, and organ failure over time. And then in the bottom right, this would be a traumatic brain event, you know, a stroke, TBI, hypoxic encephalopathy from an event. And then you're very familiar with the bottom left, which we see in dementia, frailty, neurodegenerative disease like Parkinson's disease. And that's sort of what we expect. And it's hard to relay that to patients, to say, well, where are we in that? And does it matter? You know, are we more towards the left, more towards the right? It really just depends on what else is going on, how vulnerable, how frail they are, what sorts of comorbid conditions they have. But that's our trajectory. And I think sometimes it's useful in discussions with patients when we compare it to other trajectories and say, you know, we don't have the sort of milestones that we might have in MS with exacerbations or with ALS with that sudden drop off. We don't have that typically in Parkinson's disease or Huntington's. But just one point to highlight here. When it comes to symptom profiles, I've already mentioned that idea of invisible symptoms. And some of those include the cognitive side effect or the cognitive symptoms, behavioral deficits that patients have. So not all cognitive, deficits lead to dementia, but it's pretty common. If somebody lives long enough with Parkinson's, 20 years, 80% of people develop dementia. And that's a stark reality. Another myth that we used to tell patients at the time of diagnosis was, not a given that you're going to get dementia, or at least poo-poo it. And it's not, again, that we want to clobber people with a lot of bad news, but we also don't want to set expectations that they're never going to have cognitive problems, let alone dementia. So the most common cognitive trouble that patients are having earlier on in their Parkinson's and occasionally in HD early on is just word finding difficulties. That sort of tip of the brain, tip of the tongue phenomenon where people they know what they want to say and they just can't find it, and it'll come back to them after a few minutes, which can be really frustrating. And that's a common initial problem. And then over time, dysexecutive function becomes more prominent in people living with PD. Social isolation and loneliness is also a big component of living with Parkinson's and Huntington's, and diseases that often have cosmetic effects, right? People with Huntington's having chorea, similar people with Parkinson's having dyskinesia, often appear as if they're drunk, they're staggering around, they might not want to be seen like that. Sometimes HD patients have less insight into how they appear, so they might not be quite as isolated, at least in the beginning, but Parkinson's patients often are, in part due to cosmetic effects. Many other effects as well. Apathy is another driver of social isolation, but cosmetic effects are important to think about. Drooling might be something that really interferes with people wanting to go out and engage. There's just a whole host of potential symptoms that cause isolation. Communication difficulties, not just that tip of the tongue phenomenon, but really just feeling like they can't engage in conversation. Maybe it's because they have hypophonia. Their voice is so soft, they just don't feel heard and therefore aren't going to engage in communication and therefore not go out. And then the invisible symptoms, fatigue is so prevalent in Parkinson's and in Huntington's and a lot of our neurodegenerative diseases, and hard to treat a lot of times. Certainly we want to look for sleep disturbance and something we can address in good sleep hygiene, but oftentimes the fatigue isn't related to that. The social stigma of having a brain disease is huge and sometimes overlooked. And I think, especially for patients that are in jobs or have careers that are cerebral, or they have hobbies that really engage their brain and now they have a brain disease, this has a tremendous impact and leads to questions around identity and so forth. A lot of topics that are ripe for discussion with our spiritual care support team. Then the fear of dementia can be another source of challenge and worry. And then there's a wide array of additional symptoms. People with Huntington's sometimes develop seizures, So all of this to say, there's just this wide range of symptom profiles that impact quality of life, social engagement, and the burden of living with such a condition, often for many, many years. When it comes to symptom burden with Parkinson's disease, this graph was a survey done a few years ago showing a whole host of different symptoms and how much control or how well controlled these symptoms feel in patients. So I'd like to see those orange bars being lower, showing that they're better controlled. But symptom prevalence, the top three here are fatigue, slowness, stiffness, and then pain, often overlooked as pain as a symptom in the setting of Parkinson's disease. And one of the initiatives as part of this study was to make sure that different sites are asking patients about pain, because either patients don't think their pain is associated with Parkinson's and don't bring it up, and therefore it becomes under-recognized, or also providers don't think to ask about it. Many of the sites have said, well, if I ask about pain, then I have to do something about it, which I understand. Before I had palliative training, my line was, you wouldn't want me to prescribe opioids because I'm not really good at it. Like, it was a real cop-out, I must admit. And I feel a lot more comfortable with it now. However, pain isn't always about opioids, certainly. So anyway, a lot of symptoms that are under-recognized and poorly controlled. And we have our work cut out for us when it comes to conditions like Parkinson's and the host of different symptoms that we can try and address. So again, symptoms can interfere with communication. Abulia can be apparent in Parkinson's and a whole host of other neurologic conditions. And this is sort of a syndrome of hypofunction. It's a lack of initiative in conversation, spontaneity, drive, apathy. You kind of know it when you see it. I remember as a resident, there's a certain area in the brain, I think it's the anterior cerebral artery. When you have a stroke there, you can have abulia as a result of that stroke. And I remember trying to engage with the patient, and they were so not wanting to engage with me. And our attending said, let's call the patient on the phone from outside the room. And we did. And they were much more engaged for some reason. The abulia was only present when we were with the patient, but less so on the phone. Aphasia, difficulties with production and understanding of speech can be common in both Huntington's and Parkinson's. Anosognosia, I'm sure you see a lot in dementia patients, the inability to recognize that they have these deficits, not necessarily denial. It can be a hard thing to tease that out, but the inability to recognize it as a result of the brain disease. The cognitive impairment naturally can sometimes lead to, or often lead to, difficult, limited, or no capacity to make medical decisions. Then the dysarthria and anarthria can interfere with communication, as well as pseudobulbar affect. Let's not forget about that. That can occur in a variety of neurodegenerative diseases like Parkinson's disease and the atypical Parkinsonisms. Remember, pseudobulbar affect is inappropriate response emotionally, usually in the form of crying. Can happen with laughing, that's less common, but patients just have this sudden onset of tears, right? And they cry, and oftentimes they're like, I don't know why this is happening. Or they say, gosh, I didn't used to be so emotional. But this can interfere with your interpretation of how they're doing, as well as their ability to communicate, because they can be overtaken by a spell of crying. It's usually fleeting, it comes and goes quickly, but you know it when you see it. And we can try and address that pharmacologically. And certainly to normalize it is very helpful, because patients are often really distressed, and the family is interpreting it as wildly out of control depression. And so if we talk about it and normalize it, that usually brings about a little relief. And then the third topic, the third potential theme in why Parkinson's and Huntington's and other movement disorders really lend themselves to palliative involvement is the existential and psychological suffering that can come with living with these long chronic neurodegenerative diseases. People often have loss of personhood. And as I mentioned before, the stigma of having a brain disease can be a really pervasive problem, especially if someone identifies themselves, their identity is rooted in what they do, you know, what they produce, their cerebral function, and so on. In fact, one of our cases that I'll show you today really wrestles with this. And then witnessing this as a caregiver, you know, they witness the progressive losses, as you see in dementia, as we see in all these neurodegenerative diseases, one loss after another. You know, we liken Parkinson's to a thief, robbing people of one thing after another, and the caregiver is along for the ride, witnessing the loss of their loved one inch at a time. And again, since I'm in the cancer center, it's a unique opportunity to sort of compare and contrast cancer care with neurodegenerative disease. And cancer can be perceived often as an extrinsic condition, you know, something to be fought, excised, you know, operated on, targeted therapies, and so on. Whereas neurodegenerative disease is often felt as more intrinsic. You know, it's hard to just imagine it as a tumor or something you can fight in that same way, and can often feel like a personal failure when you have these kinds of symptoms: forgetfulness, behavioral problems, pseudobulbar affect, clumsiness, et cetera, can feel really embarrassing and like you're failing in some way. So I think it's important to think about the perception that patients often have about their illness and sort of how they wrap their head around it. And then I don't have to tell you, caregiver needs are quite unique in these settings in movement disorders and neurodegenerative disease. Because of the profound level of physical and cognitive disabilities that can occur, you know, the caregivers don't necessarily have training in this. And certainly the psychiatric and behavioral issues can be a real issue, and they can just sort of creep in. For example, psychosis in Parkinson's disease just creeps in a lot of times, and it's subtle at first, and you don't even know it's there until you ask a question like, do you ever feel like someone's in the room with you when there's really no one there? And sometimes this is interpreted as their angel, guardian angel, or a dead relative, and they kind of make sense of it that way. But in fact, not to over pathologize, a lot of times that is a hallucination. That's a hallucination of presence. There's hallucinations of passage where they think someone passed in the corner of their eye, they look, nothing's there. These seemingly benign hallucinations are really a slippery slope to the development of psychosis later on. And it's hard when that just kind of creeps in, and suddenly you're like a frog in boiling water as the caregiver trying to deal with somebody that now has paranoia or is seeing something that is so real to them, like any of us are real to each other right now. There's no talking them out of it. So huge stressor for a caregiver. And in fact, one of the top reasons for placement in a nursing facility in Parkinson's is psychosis. And then, of course, the long duration of living with conditions like Parkinson's. People are living longer and longer with PD. My own father lived for 30 years with Parkinson's disease, and that's a really long time for somebody to be in the caregiving role. And it can be, it's a marathon, not a sprint, as we all say. And then taking the role of having to make medical decisions for the patient over time. If we don't guide and provide that support for caregivers, at least earlier than we often do, that can be a huge struggle. How to make decisions for their now impaired loved one is another burden. And then lastly, the behavioral problems and trying to get care for patients, particularly in Huntington's. The behaviors, as I said, can be rash, impulsive. They develop a tendency to not want to bathe. They just have this, not clear if it's a fear, but they just do not want to bathe. These kinds of challenges are huge. And skilled nursing facilities are often ill-equipped to handle these kinds of patients, particularly if in the case of Huntington's, they might be younger and otherwise healthy and maybe really strong. So lots of potential, this is just a smattering, but lots of potential unique challenges for caregivers living alongside someone with PD or HD. And then we've touched on this a couple of times, the uncertainty about prognosis. As I said, staging that we have is really imprecise. Those ranges in Huntington's stages were quite large. But this is the case with most neurologic conditions when it comes to making predictions. We do the best we can. We look for milestones to try to make predictions, but it's hard. And the uncertainty certainly is another layer of struggle and challenge and burden for people living with these conditions. They lose their sense of control, and it's hard to know how to plan for that. But that's where we try to come in and have these discussions periodically as a team. We talk about the best case, worst case, and most likely scenarios, in palliative care and certainly in these conditions, and talk about trying to be prepared for, the worst case scenario, hoping for the best, planning for the worst. And then, data has shown that estimating outcome in neurologic disease is more challenging, not surprisingly, than in the oncology population. So when it comes to meeting with palliative care, as I'm sure you do in geriatric encounters, trying to have goals of care discussions is really pivotal. And having a team-based approach is ideal, as we do in the palliative care setting. We're talking about substitute decision makers. We're talking about advanced care planning and often end-of-life decision making. And trying to honor treatment preferences can be complicated due to the long progressive nature of these diseases. It's really hard, isn't it, to predict what your future self would want or not want. You have an idea in your head of what Parkinson's is going to look like down the road based on maybe the celebrities who are out there, Michael J. Fox and others, but we really don't know. So these discussions can certainly be fraught, but I think having them checking in over time is one way to try and combat that difficulty. But it is hard given the length of time people might be living with Parkinson's. And Huntington's, people might be making decisions based on what they witnessed in their parent with HD. So does that make it easier? Not necessarily, but a little different than a case of Parkinson's that's not genetic usually. So let's get into our cases. This first case of the two, again, both have Parkinson's. This first one is more of a primary palliative care scenario where we're trying to investigate goals of care and then make a treatment plan. And you'll see the major overlap between geriatric medicine and how we approach this case. And the concept of total pain, you may be familiar with, is a palliative concept first coined by Dame Cicely Saunders, who's responsible for the modern hospice movement and then palliative care. And it's the idea that pain as a physical symptom is far more than just physical, right? There's emotional aspects, spiritual, et cetera. And we try to treat other symptoms in that sort of total holistic way, trying to pay attention to the impact of the practical side of living with the symptoms, as well as any sort of spiritual underpinnings and so on. So again, this is going to be more of a primary palliative care scenario. So we've got a 71-year-old gentleman. He was a welder. He has Parkinson's, diagnosed in 2005, and then 10 years later underwent bilateral subthalamic nucleus deep brain stimulation surgery, DBS, which allowed him to take less levodopa for a while. Unique to him, not common at all, is that he also developed axial weakness and muscle wasting and was found to have a neuromuscular disease as well, with a genetic variant of unknown significance. So that complicated things a bit. And when you see him, you'll see his neck kind of pulls backwards, which is not common in Parkinson's. It was more of a feature of his neuromuscular condition, which was not being treated. There was no known treatment for that. But he had worsening slowness, bradykinesia, imbalance, and severe knee pain. And his MoCA was 25. He had REM sleep behavior disorder, as often happens in Parkinson's, the majority of people actually. He had neurogenic orthostatic hypotension, so he was being treated with midodrine, as you see there. He started to have illusions. Remember that slippery slope I mentioned of psychosis often starts with also illusion, seeing something that is there and misinterpreting it as something else. And he had depression. So here's his description, trying to understand the lived experience for him. So remember, this is probably 15 years into his Parkinson's, and he's explaining what it's like.
That you cannot do things on your own. That you've got to be smart enough to know what your limits are. The body's just kind of unforgiving. In fact, you owe me some rest.
We know we've been robbed of intimacy, that we don't get to go all these places together anymore. It's a challenge even going out to eat. We don't even do that anymore.
Just a snapshot of life for them. So the goals of care conversation revealed that prior to Parkinson's, he'd, like I said, been a welder, and he worked on pipelines for decades. He really liked that. In fact, he said, it never occurred to me that there'd be a time when I wouldn't work. I thought I'd work until I die. When he wasn't working, he enjoyed fishing in streams, rivers, camping with his wife. He took trips around the Southwest, did some four-wheeling, pretty active guy. Things that bring him joy. He sought activities that gave him a sense of purpose. When I met him, he was considering running for the board of his HOA. And that's a mixed blessing in a lot of cases, but he was highly sought after by his neighbors because of his background with pipelines and all of this. He had a lot of knowledge and a lot to offer them. So he felt like, valued in that way. He, of course, loved time with his grandchildren. That's really what he was living for. He was most worried about finances for his wife if he died first. And I do know how this case played out. And that wound up not being an issue, but yeah, that was his biggest worry. So a very kind man. He was hoping to continue to walk, to maintain his cognition, and to focus on quality of life. So these primary palliative interventions are not dissimilar to what you would do in your clinics for sure. He had freezing of gait, where he would get stuck when trying to initiate walking, and worsening imbalance in part as a result of that. So certainly physical therapy is always a good idea. And we got him a nitro walker, one of those red ones, which helped. He was a really tall man, so it was a big deal to get it high enough for him, but that helped a good bit. For his depression, we started duloxetine. We also got him some at-home counseling, and the chaplain meetings, both with him individually as well as with his wife, wound up being really helpful for him. He also described apathy, and his wife is a really social person, and she was really bothered by this. And so we engaged Wiser Mind, which for him was really helpful. He gave really good feedback about it, the sort of brain enrichment program that they did, and it helped him feel more engaged, it seemed, with his HOA once he became involved with that. Naturally, we started a benzodiazepine for his REM sleep behavior disorder, and for the knee pain, he got some ultrasound guided injections. We got him a medication alarm. And then the caregiver burnout piece was pretty big. She, as I said, was a very social person. We got respite care for them with the help of our social worker. We gave her permission, so to speak, to take time away and do the things that she wanted to do. She actually joined an adult sorority, which she found really a source of enjoyment. She also benefited from the chaplain meetings, and she got involved with our support group. So it wasn't like a panacea to have palliative care involved. However, we did make some big gains with them. And this is him explaining what quality of life is for him.
to explain my qualities. It ain't bad considering how other folks are and what I'm able to do and still have new days. I have bad days, but also have new days, which is being godly in bad shape.
So that was his case, just sort of an overview of some potential opportunities for helping in a variety of different ways, spiritually, practically, medically, and so forth, and trying to collaborate with interventional pain and so on. So our second case is another gentleman with Parkinson's disease. This focuses more on taking the goals of care and what's most important to him and helping him make a tough medical decision, which, you know, as a provider, we may not have made the same decision. Depends how you look at it. But this I think is particularly unique. Oh boy. Oh, good.
Lynn is a super guy, and he's very gregarious, outgoing, self-confident, adventuresome, a leader. Yeah, he was president of his class and that kind of thing. Just, you know, full of life. And let's go do this, let's go do this, let's go here. So it's been an adventure being married to him. Yeah, good guy.
I was able to lead a very active life and a very fruitful and productive life. I have a fabulous family, and we traveled extensively over the years. I think we visited about 70 to 75 countries during those pre-Parkinson times. I spent my entire life in academic medicine, and fortunately, that went very well. My career went very well, and that allowed us to travel and lecture.
So he's at the time 79. His Parkinson's was diagnosed in 08. He started with symptoms 2 years prior to that. Ultimately, he received, instead of DBS, the other advanced therapy, Duopa, which is carbidopa-levodopa suspension sent into the gut through a pump, maybe like an insulin pump, but a steady infusion into the gut of levodopa. And he got that in 2017. And to this day, it's working really well for him. Comorbidities, AFib, ablation stent, bilateral hip and knees replaced, and an L5S1 fusion.
64, roughly 64, in the age when I noticed that my handwriting and some other stuff swinging up.
We've had to switch gears. We've had to make some alterations. Can't travel like we used to travel. Activities that Lynn has had to give up some activities, his tennis, his biking, some of the things he really enjoyed.
So important for him, in 2018, he came to me. That's the first time I saw him with this document that he wrote, saying, look, most important to me is my cognition. You can imagine with his history, his career, he prides himself on his intellect, and the idea of developing dementia is absolutely not acceptable to him. And he wrote a document stating that, you know, if it gets to close to that point, he wants hastened death. And we've talked through that a bunch about what's legal and so forth. And that remains a really big, important topic for him. And it guides his decision making, which you'll see. And he's been diagnosed with MCI, which I've seen progress over time, but he remains, you know, he has capacity and so on, but it's harder and harder for him to get the words out and to participate in group discussions with his family and so forth. His goals as of 2020 were to never be in a wheelchair. Unfortunately, he had 2 major falls. He fractured his femur in 2019 and then on the right and then on the left in 2020. Severe pain resulted. He already had pain, but now with severe pain referred to the knees and became essentially wheelchair bound. Found to have bilateral loose femoral components and failed bipolar hip arthroplasties, and they proposed surgery. The orthopedist said, hey, we're going to revise both hips. We're going to do the right side, and then 4 months later, we're going to do the left. And the best case scenario here is that we're going to be able to get you walking again with a walker and reduce pain by 75%. So that was the proposition. And henceforth comes the decision making.
We finally had the meeting with his PA. And that's one that really hit us, how serious the surgery could be. The risks involved. He was signing it. And he actually went through the process of signing all the papers. Got that far. And, you know, this could happen, and this could happen, and a lot of blood loss, transfusions, and anesthesia for over 4 hours. We left that meeting, and both of us were just blanched.
Maybe I couldn't walk very well. Maybe the pain, maybe the pain went away. But the cognition that will occur, it's happened in the past, may be so big and so bad that that was included in the picture.
What?
Cognition. Really loss of ability to be a person that I am. Being able to direct my family.
At this point, the girls had weighed in and said, you know, what could you maybe gain? Maybe being able to walk a little bit with a walker, then you risk falling again, versus maybe not doing the surgery and accepting your life as the way it is now, in a wheelchair or a power chair. You know, we have to explore.
At the age of 80, I'm going to take a year out of all this stuff. And then I'm not sure what the results will be at the end. You know, there's no guarantee that, I mean, Dr. Dennis thought I'd be able to walk out with a walker. Pain would be improved 75%. So I still can do a lot of things. I might not be able to do as much work as any of those things a year from now.
We had a lot of, needless to say, family meetings, discussions with the surgeon about, you know, risks, benefits, burdens, but also what's the risk of cognitive impairment as a result of the surgery. He wasn't so concerned about infection, transfusion problems, all the stuff his wife listed. He was really exclusively concerned about cognitive loss as a result of general anesthesia and going through all of this rigmarole at the age of 79 or 80. So Parkinson's and surgery is an important topic. There is an increased, of course, risk of nosocomial morbidity. Dysphagia can be a big issue after surgery, whether or not they had significant dysphagia going into it or not. It's 50 to 80% in people with Parkinson's, which would lead to aspiration pneumonia potentially and malnutrition. This is all comers with Parkinson's undergoing general anesthesia for surgery. They can also have a risk of decreased respiratory function perioperatively due to the slowness and insufficient respiratory muscle movement, also increasing pneumonia risk. Increased falls after surgery, bladder infections are huge, and these can be major setbacks. And then getting medications on time in a hospital is really tricky. And this gentleman has Duopa, which I would imagine a lot of nursing staff hasn't seen before. So they would have to temporarily give him orals, and getting those on time is really hard for people living with PD. And so I'll cruise through this, but there are all sorts of potential complications for those living with Parkinson's perioperatively to be considered. Of course, his focus was on cognitive trouble. And it's very common when somebody has moderate to severe Parkinson's post-operatively to have several days of delirium and confusion. And it takes a while for that to clear. It can be really scary for the patient and the family. So post-op cognitive dysfunction, as you know, is post-op memory or thinking problems. And this has been corroborated by formal neuropsychological testing showing before and after actual changes. Specifically, in processing speed and inhibitory functions, frontal lobe dysfunction that they may have already had really exacerbated as a result of surgery. In one study, a pilot to examine this back in 2015, patients with PD undergoing orthopedic surgery, 80% of PD surgery sampled experienced cognitive decline greater than that of their age-matched controls, their peers. So that's not insignificant. So the outcome as we wrap up here.
Let's forget surgery.
Let's forget the surgery.
Wheelchair, but it's not a total zero. I can do things.
So it became pretty clear that was the right decision. And as Lynn said, I don't think either one of us has looked back. It seemed like it was the correct decision. So guess who's boxing twice a week now and really enjoying it. And no problem. They put the bag right in front of him and away he goes. So he is more active than I am.
So a nice outcome in that case. This was a couple years ago. So interestingly, more recently, he considered an elective colostomy because bowel movements, incontinence, and so forth have really limited his ability to go out or his feeling comfortable going out. It was his, I think, wife's suggestion. She's also a very social person like our other wife. And for a moment, he considered this, and the surgeon was like, I'll do it. And it'll be really brief anesthesia, like 20, 30 minutes. And same decision, not gonna go through that. Even for less than a half hour of anesthesia, he opted to not do it. So he's now, obviously wheelchair bound. He has poker games at his house and his garage with friends who come over to his house. That's his big social event. I don't think he's boxing anymore, but still not regretting his decision to remain relegated to a wheelchair and avoid having gone through multiple, 2 surgeries and all the rehab and all the potential complications. So I hope I impressed upon you that movement disorders highlighting Huntington's and Parkinson's disease have trajectories that are important to consider, difficult to prognosticate, but really unique symptom profiles, a lot of opportunities for additional support in the area of helping support with existential emotional suffering. The caregiver needs are quite unique and potentially long courses of illness during which caregivers need a lot of support. So the 2 cases addressed sort of the idea of total pain or a comprehensive approach to thinking about living with Parkinson's and all that it can impact, both the obvious motor symptoms as well as the invisible symptoms. And then the second was more of an exploration of value-based goals of care discussions and how they can really help guide in medical decision-making when we engage in that with patients over time. Little quick plug for the International Neuropalliative Care Society. We had our 3rd meeting. It was the first in person. Hillary and I were there together last week in Minneapolis. INPCS consists of neurologists, geriatricians, social workers, nurses, caregivers, patients, et cetera, et cetera. Check it out. And that's all for now. Happy to take a question or 2. I have time if you have time, but up to you all.
A quick question from the chat.
Mm.
Do persons with advanced symptoms of motor disease feel old?
A lot of times, yeah. I mean, when we hear about Michael J. Fox, who got Parkinson's at 30, it's an old person's disease. And trying to wrap your head around being a younger person with an older person's disease often does make people feel old. Every now and then, though, we hear a patient saying, I know that, I have all this motor dysfunction, but I don't feel so old. But I think my experience anecdotally has been oftentimes, it contributes to them feeling older because these are classified, not Huntington's, but Parkinson's is more of an old person's disease, even though it can have young onset.
There's a question about maybe attendance. Given we want to have sort of a separate discussion, people at the staff as well as Eric Campbell and others. I wanted to ask if there are community-based options for chaplain meetings or spiritual support that you found in our community.
That's a great question about community-based chaplaincy. I don't think I have. What's different about our clinic now, as opposed to our earlier version of neuropalliative care clinic, is when we were based in neurology, we used to have the chaplain as part of our visits, our medical visit exclusively. Now with palliative care and our joining forces, the patients can meet with the chaplain completely separated from visits with us. They have individual meetings virtually or in person. So it's almost like community. We don't bill for that. So it's as close as we have gotten to being able to provide that. And often our spiritual care. So we are about to have 3 chaplains, which is such a blessing. They're all partial, right? And it will ultimately be 1.3 FTE in chaplain support, in part philanthropically supported. So hopefully it will last. But as a result of that, we feel confident we're able to provide a decent amount of spiritual care, pseudo community based. Thank you. Just a quick second plug, Parkinson's, as we talked about, and hospitalization, really tough. There's a free kit patients can send away for through the Parkinson's Foundation that highlights what medications are contraindicated and other helpful things to advocate for themselves when they're hospitalized. Just want you to be aware if you're not already.